I'll start off on that note. Um, I have a few, just one disclosure. I have received a consulting fee from Ozuka Lundbeck, specific to issues regarding a single product, unrelated to this presentation. This program has not received financial support from any commercial organization, no relationships or potential conflicts of interest to disclose. I have developed the content for this presentation. My involvement talk is very broad and not specific to any pharmaceutical products or categories. When promoting certain class of medications, for example, oral medication or depot injection, specific choice of products will not be mentioned. Generic names of medications are used in place of brand names. All recommendations are on label following national international guidelines. So to start off with, inadequate treatment of psychosis is not acceptable. We need better outcomes in treatment of psychosis. And what we mean is improve symptoms, improve general health and prognosis for these clients, help improve the functional outcomes, for example, the housing, the employment, social and recreational life, improve quality of life, reduce suicide rates, help them reduce medicating themselves with recreational substances in the hope of feeling better, reduce involvement with legal justice system, reduce admissions and readmissions to hospital. Now, this is a Vancouver Sun headlines from 2018. BC has second highest hospital readmission rate in Canada, solutions elusive. And what we are aware is in VCH, psychosis is the #1 cause of readmission to acute psychiatry within 30 days of discharge. We have had several barriers, challenges in the treatment of primary psychosis, including identifying them in the first place. A lot of times it's clouded with complexity, not least because of substance use. Lack of evidence-based approach to treatment, lack of measurement to quantify the symptoms so that we can administer the treatment appropriately, inadequate trial of medication, non-adherence issues, lack of resources, training and support to use clozapine in the community, and lack of inpatient beds where they are indicated. What we know is that 25 to 30% of clients who suffer from schizophrenia or schizoaffective disorder meet criteria for treatment-resistant schizophrenia. That is, they did not respond adequately to a trial of 2 antipsychotics. About 30 to 60% of these treatment-resistant clients respond to clozapine. We in BC have only 17% of our clients with this condition on clozapine, whereas in Australia, the percentage is 30%. So we have to go up quite a bit to get there. It is associated with 18.6 fewer inpatient days per year per patient treated. It was associated with lower all-cause mortality, both natural and unnatural after adjustment for confounders, as was found by Richard Hayes in 2015, published in Schizophrenia Bulletin. And also important to remember, schizophrenia showed highest number of quality adjusted life years out of all antipsychotics included in the analysis. It even dominated commonly used risperidone and olanzapine when used as third and fourth line in the treatment of TRS. Now, just imagine someone getting the right treatment at the age of 20 years as opposed to getting it at the age of 50 years. they have lost all the opportunity to educate themselves, to build a relationship, to build a bank balance. Now, we went about a number of different ways to find out the status of these clients. One way we did was reviewing the charts at a mental health team. We reviewed about 50% of those clients, and about 50% of them had schizophrenia or schizoaffective disorder. We looked at it in two different ways. The first one was clients who were on clozapine, and the second one was clients who have never been on clozapine. So those two charts representing them. So if you look at the first chart, there were 52 clients who were on clozapine, and of them, 66% were kind of appropriate in that the 31% arrived on clozapine. The other 31 started after they failed one antipsychotic at the team, basically meaning they tried another antipsychotic elsewhere before coming to that mental health team. And the 4% is for people who have tried clozapine after trial of two antipsychotics. So this is an underestimate, but there's an improvement for up to 34%. Now, looking at it in another way, looking at clients who have never been on clozapine, there were a total of 105 clients. And of them, 24% were on the first antipsychotic, 26 on the second antipsychotic. So only about 50%. So the third should have been the clozapine, but they have never been. So that's like 50% of those clients who have never tried clozapine. Now, this was another way of looking at what the situation was. This was surveying psychiatrists and some family physicians who were working at the mental health team. 50%, just over 50% had initiated clozapine during their residency for 5 years. And only 20% of them actually did it in the community. So it's not very surprising people don't feel comfortable doing it in the community. Then we looked at what these physicians feel are the barriers. They said their clients are afraid of the clozapine, the side effects. They did not have access to specialists. They did not have the time. Whoever was performing the duty doctor's role did not have protected time to do this. The case managers did not feel equipped. Some of them did not have training. No support when they are not around at the team, because most of the physicians work few sessions at the team. And then ordering titration for clozapine was very complex and difficult. And then poor equipment. The way we work is very different. We do not have blood pressure machines in our room, for example. And then we asked them about what would help them. And a lot of them felt it would be helpful to have a dedicated clozapine resource nurse, to have easy access to AAC, AHBT when it was necessary. A lot of them felt it would be good if someone like AHBT or AAC can do, but I think that resource very much busy with doing inpatients. And there are difficulties outsourcing. Easy access to inpatient is lacking, so patients who need inpatient starts, there's a bottleneck there. And then to summarize, I think the barriers to clozapine were patient acceptance, problems with outsourcing clozapine to outside team, for example, the AHBT team. I think often the physician would be different. It would be start from the scratch, and the physicians who are working at the mental health team would lack the knowledge or ability to monitor them for the rest of the 50 years once they have started on the clozapine, if they need to be on it for that long. Inadequate training and ongoing CME, lack of inpatient resources where they are indicated, lack of local resources within the mental health teams in terms of equipment, space, and human resources. And what do we have to improve? Need for improving client acceptance through producing materials like videos, leaflets for both the clients and the families to make the right decision. training the staff on educating the clients on treatment optimization, early introduction, clarifying risks, risk management and benefits, motivational interviewing, insight orientation, and adherence therapy. And then we've identified a number of things that can change for better, creating a local working group for clozapine, creating the role of a clozapine resource nurse at the team, creating more appointments for clients who are starting clozapine titration, creating provision for non-nursing case managers to deal with these titration issues, creating space and time for the duty doctors at the team to cover for absent colleagues who are on clozapine titration, creating space for home visits for clients who are non-adherent on clozapine, creating out-of-hours support network through AAC and emergency room, creating provision for equipment like blood pressure machine, informing and involving family physicians from the start, creating preset forms so that the titration can be streamlined, as well as monitoring for side effects, creating easy access to specialists in cardiology, hematology, for example, creating easy access to admission to emergency room or inpatients or venture where it is warranted, and creating provisions for daily dispensing for the duration of the titration. So on that note, I will kind of refer you to a couple of articles on these issues, unplanned hospital admissions to British Columbia. And as you've already heard from Professor Horner, guidelines on pharmacotherapy of schizophrenia in adults. And finally, I would like to end with this quote: "There is hope even when your brain tells you there isn't." John Green, author of The Fault in Our Stars, New York Times bestseller.